Okay, so a warm welcome to all the attendees, all the participants for the first ISNTD Connect session of 2021. Happy New Year to everybody. I think I can still get away with saying Happy New Year. It's the 19th of January, so I think it's okay to wish everyone a happy 21 and hope it started well for everybody. Very honored and happy today to be joined on this webinar with Angus Thomson. He's the senior social scientist at the Demand for Immunization project at UNICEF. So hi there to Angus as well. Before we I thought we'd give you a bit of an introduction to this particular webinar. We've had a piqued interest in terms of issues around vaccine confidence, hesitancy for several years now. In fact, I had the pleasure of meeting and working with Angus. This is going back to 2016 when the ISNTD were helping to put together the Dengue Voice meetings with Sanofi Pasteur in Paris, actually, from 2016 and 2017. And I firmly remember the first time I ever heard misinformation. In fact, even digital inoculation was from Angus, very, very much ahead of the curve. That was back in 2016. That morphed into a vaccine confidence in a post-truth era panel that we put together as part of our D3 annual meeting. And that was then in 2018. From there, we then had the opportunity to work with Angus at the United Nations General Assembly, the 75th anniversary of that last year, where we had a special session there dedicated to rebuilding trust in terms of vaccine hesitancy. And really, one of the kind of things we wanted to pick up on is that, as I'm sure all of you are fully aware, there's so much information, reportage around the rise of scientific populism, hand in glove with, I guess, political populism. It's really the flavor du jour and has been for some time. And we felt that instead of just describing that, so we wanted to look at it through the optic of potential solutions. I mean, we're in a situation now where, obviously, I'm sure you all know, the global death rate from COVID is over 2 million people have lost their lives so far. It's daily case rates are kind of over 500,000 globally, with the kind of caseload so far, 95 million people. So the numbers are staggering, and they're not just numbers. I myself was, I'm sure we've all known someone who's lost their life or, sadly been affected in some way or another by COVID. So it's very real. We need solutions. And so we were absolutely delighted to see this report when it came out. The two principal authors, Angus Thomson, who's here with us, and Gary Finnegan, an award-winning journalist who's very much involved in the Vaccines Today news feeds, amongst other global health issues. So we're very honored today to be joined by Angus. And I think I'll just finish off by saying there's a really interesting parallel. The vaccines that have come to, into the online, as it were, the Moderna, the Pfizer, the AstraZeneca, all kind of underpinned by real collaboration. And when you look at this report, you look at the collaborators on there. It's not just UNICEF, but it's the Yale Institute of Global Health, First Draft, the Public Good Projects project as well. A real sense of collaboration. And from that synthesis, we've got a real interesting set of potential solutions to how to tackle this. And so I think that's enough from me for now. One bit of housekeeping. If we could ask, we've got 573 people registered for this, but if we could ask people to, give a shout out on the chats in terms of your name, affiliation, put that out there. We're seeing people from Nigeria, Dr. Nebe, Dr. La from Nigeria. We've got people from London. We've got Manoj Grover from India. Hi there, from Sokoto. We've got, I think, Indonesia, Canada, the UK. So it's a very, very large spread of people. I think that's enough from me, and I'm very excited to kind of hand over the floor to Angus Thomson, and over to you, Angus. I'm going to back out and I'll join you back for the Q&A after. So I'll just back out. Over to you. Thank you.
Thanks, Cam. Thanks for that introduction, and thank you all for joining. Thanks for your interest in the subject. As you pointed out, Cam, we were thinking about this 4 or 5 years ago. I'm not sure we could have predicted this kind of confluence of events that lead us to, as the WHO calls it, an infodemic that has paralleled the pandemic, the COVID-19 pandemic. On the one hand, it's not surprising that we're seeing conspiracy theories, for example, spreading and getting traction in times of heightened anxiety, of heightened uncertainty. We know that under these conditions, for some people, conspiracy theories actually provide a level of psychological comfort almost. We know that they give people, if not a sense of agency, at least an explanation for why they're feeling powerless. We know that conspiracy theories help people simplify and make sense of complex situations. So it's not surprising that we have this parallel infodemic. When I joined in UNICEF last year, I was tasked with figuring out what it is that countries would need to manage misinformation in relation to vaccination. And following a principle that I've always followed in my career, I reached out to the people who really knew what they were doing in this area. And as Cam touched upon, 3 partners, each of which bring a different element of expertise and experience to the table. So I'm delighted to present today on behalf of UNICEF, who have strongly supported this work, but also those partners, and I'll loop back to them. I don't want to spend too much time introducing misinformation. I think every second news article is about misinformation now. Journalists are asking the right people, they're interviewing the right people, so a lot of those articles really are smart and helping us make sense of the situation. Some of my introduction is a little bit scene setting, and so I think I'm going to go fairly quickly through that. What I'd like to get through, as Cam referred to, is to introduce the Vaccine Misinformation Management Field Guide. The aim of this guide is to provide countries with a way to set strategy and to develop action plans to manage misinformation. So if I leave you with one thing by the end of this, it's that we can't manage this challenge to our immunization programs through any haphazard approach. We need strategy. We need strategy that embarks multiple partners, and we need strategy that joins up what we're hearing with what we're understanding, with what we're doing in the field, in a virtuous cycle, so that we become better and better at understanding people's questions and concerns and answering them. But let's have a quick look. So Tedros said, we're not just fighting an epidemic, we're fighting an infodemic. My colleagues at PGP in Project Vector, which is providing social listening support to over 300 public health departments in the US, identified a doubling of vaccine critical messages. In fact, I should have updated this. It's closer to threefold when we looked at it in September. We have analyses from the Center for Countering Digital Hate, 3 analyses now, actually 3 excellent analyses, but the first one, which identified that this is not happening by chance. So there is actually an industry, and that industry is probably worth around $1 billion, that is making money from anti-vaccine disinformation. And we'll see as we go through the presentation how that might be happening. This is a very early analysis I did in April, May. the aim of showing this is to highlight the fact that misinformation is very much like the coronavirus itself. It spreads rapidly, it mutates and adapts. And so a rumor that we started tracking very early on in Francophone Africa that pivoted around the idea that Africans were being used as guinea pigs to test COVID-19 vaccines, spread across the continent, adapted so that in the Comoros Islands, it was referring to Comorians. In Madagascar, it was referring to the Madagash. It took on different forms in different countries. It seems to have faded. We're picking this up in offline social listening, but not so much in online social listening. But the point is, maybe as the WHO has championed, we do need to think about misinformation, using many of the kind of principles, the frameworks that we use to think about infectious diseases, at least to help us to start structuring our approaches, our understanding and our approaches to dealing with it. And so we have recoined the idea, the field of infodemiology. And as you'll see, our proposition is that much of this work should pivot around a function that we call an infodemic manager. So very quick definitions. People need information to start to decide on their behaviors. It's essential, but it's never sufficient to change people's behaviors. It's what we use to make sense of the world, so it's data with meaning. But to actually start to have an influence on what we may decide to do, it must be actionable, it must be sticky, and I'll come back to this, and it must come from people that we trust, from people who are trustworthy. Misinformation is unintentional falsehoods. There are different definitions of these. It can dilute, distract, distort, as people are seeking good information, trying to make sense of this complex and uncertain world that we're living in at the moment. An important distinction is disinformation. Disinformation is deliberately engineered falsehoods. So it is designed with malicious intent. It is designed to deceive, to stick in people's minds, and to spread effectively. It's like an engineered virus. And this distinction is important because it's important that we're able to distinguish between information or a lack of it, misinformation and the confusion that it brings, and this malicious disinformation in order to shape our strategies. The question that I always ask is, when people start throwing their hands up, is that's all very well, but is it actually influencing people's perceptions and behaviors? We know it is. There's an increasing body of data to show that misinformation is indeed impacting the decisions that people are making. I won't go into this today. I'll be sharing these slides afterwards. People can start reading some of these references. There's a lot of new references that have come out. I haven't updated some of these slides. An important point about misinformation is that it is psychologically sticky. And I've learned this term from experts in the field. What we find is that people will often continue to rely on misinformation that has been corrected in their subsequent reasoning, even if they understand and believe the correction, and even later remember the correction. There are many reasons why it's sticky. One way I look at this is and this is not evidence-based. There are two, for me, universal human values. One is that no one likes to be told that they're wrong. And the other is that nobody likes to be fooled. Nobody likes to feel like someone's pulling the wool over their eyes, tricking them, making fun of them. And so when we try to correct somebody misinformation in someone's mind. We may be telling them that the misinformation is wrong, that their information is wrong, but people often hear, "You are wrong." And so there's what's called a righting reflex, where we actually can increase people's reactivity, their psychological reactivity, and that will increase their resistance to assimilating the correcting information. We know that when we try to correct with fear-based appeals, that this can often backfire. We know that the more you hear something, the more you believe it is true. So Kahneman said a reliable way to make people believe falsehoods is frequent repetition, because familiarity is not easily distinguished from truth. So this has an important impact on the way that we address misinformation. And often misinformation is assimilated by people because it fits within their worldview, and therefore when we try to correct it, we're not just trying to correct the misinformation. People don't feel like we're trying to correct the misinformation. They feel like it's actually an assault on their identity, on their beliefs. So in many different aspects, misinformation can be psychologically sticky. I want to just 2 words on what we understand about vaccine decision-making, vaccine acceptance. First of all, it exists on a continuum. In any population, very few people actually refuse all vaccines. The majority, at least for pediatric immunization, just accept it. So it's a social norm. And really a big part of our job is to understand the more volatile group of people who we might call vaccine hesitant, who may question vaccination but still vaccinate, who may accept some vaccines but not all, who may delay vaccines, who may refuse one vaccine, etc., etc. So this is a very heterogeneous group, and it's a group that is there's a level of dynamism here. It's dynamic as well. You know, an individual can have a different position on this continuum at different times. The second thing I want to leave you with is that our decisions, our vaccine-related decisions, can be affected by a number of different social or psychological factors, and those factors can actually run quite deep. So this is all based on evidence that we have. At a more superficial level, we know that thoughts and feelings obviously may influence people's decisions. Getting a bit deeper, attitudes and cognitive biases, those psychological shortcuts that we've relied upon for hundreds of thousands of years to manage the complexity of our world, but even more deeply social norms, as I've touched upon, and importantly trust, and I'll come back to trust, our beliefs, and even more fundamental, these universal moral values. We've identified a couple of these that seem to be linked to people's decisions, our worldview, as I've touched upon. So there's no quick fix, there's no silver bullet. We need to understand what's behind people's decisions, what's behind a community's decisions or an individual's decisions, what's behind it at this particular moment in time. And we need to frame our engagement with those communities, those people, accordingly. So 3 years ago, Time asked this question. I don't think anybody would argue about the answer to this question, but 3 years ago, we were still asking it. Yes, we're in a post-truth era where we have, a president of the world's largest democracy, making literally spouting dozens of falsehoods every day. Truth is important when we're looking at immunization decision-making and misinformation. And truth is intertwined with trust. So truth and trust are fundamental pillars of people's decision to get vaccinated. And most importantly, trustworthy. So our truths come from the people that we deem to be trustworthy. That means someone that we deem to be credible, to be expert about what they're talking about, but even more importantly, to be concerned about us, to have our best interests at heart. That's what makes somebody trustworthy. And this is an important concept because we need to understand who people trust, who are the trustworthy messengers, because they're the people that should be speaking to the public, the concerned public. So the flip side of this is that what we're looking at is a combination of misinformation and mistrust when we're seeing an impact of misinformation on people's decisions around vaccination. And it's often not just the misinformation. The misinformation has to get traction, and it gets traction in a context of low or mistrust. The other contextual point I wanted to touch upon, which might be a bit redundant now, I think everybody's caught up with this. Yes, we know that social platforms are a conduit of the spread of misinformation. What perhaps some people don't understand is that this is by their ability to expose people to misinformation is by design. So social platforms are by design attractive and irresistible. They're by design addictive. So this is a quote from the first president of Facebook, which pretty much sums it up. The thought process behind building this platform was how to consume as much of your time and conscious attention as possible. Now, they did this by drawing upon the psychological sciences. They had experts, and they rapidly understood that a little dopamine hit, so this is the same neural pathway that mediates addiction to drugs like cocaine. A little dopamine hit every once in a while because someone liked or commented on a photo or a post triggered this social validation feedback loop. It's a vulnerability in human psychology. And not only did they understand this, but then they set artificial intelligence the task of refining these algorithms that they have on their platforms so that it becomes more and more addictive. And what we know is that this attention economy that was created actually favors misinformation, disinformation, because disinformation is attractive, captures our attention, is more likely to be shared, etc. So the platforms are built for the sharing of misinformation and disinformation. One point to leave you with is so that's a challenge that we have. What we understand from good research is that, in a nutshell, the pro-vaccine voices are talking to themselves. So this is a study of social network on Facebook. The blue dots are the pro-vaccine pages. The red dots are the vaccine critical pages. And there are many conclusions in this study, but the key conclusion that's stayed with me is that the red dots are reaching the undecided green dots more effectively. That means they're working from a strategy. They have strategy that they apply, and that means that their reach is broader and more effective. So the corollary of that is that if we want to reach people and encourage them, help them to make the right health decisions, we have to be strategic as well. It can't be some haphazard mishmash of great ideas and one-off interventions. At UNICEF, whenever I'm talking about misinformation in the context of immunization, I encourage people to be clear on what the issue is that we're dealing with and what our objective is. We work around three key themes. The first is tracking and addressing misinformation in near real time, COVID-19 and its impact on routine immunization. The second is we're looking at the potential hesitancy rising around the introduction of new vaccines. We've been working on a new oral polio vaccine, focusing on that, and obviously now that we have the SARS-CoV-2 vaccines, that's a key theme that we're focused on. But then we can also imagine that there are quite strong ripple effects from this pandemic on obviously the demand for immunization services, but also, the basic access to immunization services. So it's important when you start doing this kind of operational research to ask the right research question. So let me just talk, let me stop there for a second and see, Cam, if there are any questions in that introduction. And then what I want to do is jump to some solutions.
So yeah, thanks for that, Angus. Absolutely fascinating so far, really getting into that deeply. We have had some questions come through. Stephen Brahmi, I believe, is asking, are there any textbooks, journals that directly target anti-vaccine propaganda? I suppose we could, with everybody's blessing, move forward and have these at the end in terms of the Q&A. It might make for a
well, I think that certainly for that question, the next
better flow. I had a couple of questions myself. Yeah.
So shall I keep rolling?
I'll hand it back over to you. Yeah. I think that would be good, Angus. I think that'd be a better idea. Yeah, I'll move on.
Thanks. So what does the solution look like? So the solution that UNICEF and partners are putting together is to provide a package, to build and provide a package of tools, technical support, training, etc., to countries so that they can establish an integrated national misinformation management strategy. So that means with PGP, with First Draft, and with Yale, we're developing, I'll show you briefly, a social listening platform that can be customized to the needs of a country, to help them escape from the kind of the binds of the commercial systems. A field epidemiologist training program. How do we train those people who sit at the center of these strategies, who lead the social listening, who generate the actionable insights, who run the monitoring and evaluation? How do we train these as a colleague from the CDC calls them unicorns? And the Digital Interventions and Assessment Lab, which is a lab that will drive operational research, much as any company online, any retail company online is doing. How do we design and rapid test content, messages, content, interventions, both for their efficacy through rapid A/B testing, and also because we know that some vaccine related content can backfire, for safety as well. And we imagine this all supporting an integrated national strategy. So these are some of the tools that we're developing and that we want to get to countries fairly rapidly. Those of you who've done social listening with commercial systems probably understand that, first of all, you have to pay for them, and you have to pay for every user, and you have to pay for the volume of data that you can access, but also they are limited to certain channels. In particular, they may cover the major social media channels, some online mainstream media, but working at UNICEF and with many of our partners, we rapidly became aware of many different channels of data that could be providing important listening, important insights in any social listening system. So our approach has been really based on a principle of data equity. We know that almost half of the world still doesn't have access to the internet. To develop a system that would allow us to consolidate both online and offline data sources, and even what we call on-the-ground sources. So, we have social mobilizers, polio social mobilizers. What are they hearing? We have partners like IFRC who are gathering community feedback. What is being heard there, and how do we feed all of that into a single system? Make sense of that data through strong algorithms and visualizing the data, so that that infodemiologist, that infodemic manager, can manage the data, can start to identify the misinformation, set up a rumor log, can start to identify the questions and concerns that people have, and can provide that in the format of what I call actionable insights to the people on the ground doing the risk engagement, the risk communication, community engagement, communications, social mobilization, etc. So we're working with PGP, who are already running the Project Vector system. We see this as a customizable system that we would like to, embed within immunization programs, so that this social listening becomes a routine process. That's one part of the solution. Second part of the solution is to have a national strategy. We can't manage something as complex as this without a strategy that helps us make sense of an evolving situation, that embarks multiple partners who might be bringing different important strengths to the table, and that most importantly couples our listening with all of the work that we're doing in the field. The Misinformation Management Field Guide that has already been shared with you and that you can see again, you've got the link here again, is currently available in English and French, Spanish, Arabic, Italian coming soon. Portuguese, I'm looking for a translator if anyone would like to. We've had a wonderful offer of volunteer of translation for the Italian version. We'd like to get this in as many languages as possible. The fundamental aim of this guide was not to provide yet another guide talking about the social and behavioral determinants of vaccine decision making. It was to help countries set strategy and rapidly pull together action plans that draw upon the current evidence of what works in terms of addressing misinformation. So the guide is freely available there, and I would encourage you to have a look. You'll hear echoes, you'll read echoes of some of what I've said, and hopefully it'll take you much deeper into some of the points that I've made in my introduction. But most importantly is the strategy that it helps set. Now, there are many different ways of coming at this. There's no perfect operational framework, but we worked to come up with a framework that could at least help countries to ensure that they're not missing any of the key steps. So we organize this around a simple listen, understand, engage cycle, essentially. The preparatory work that we're currently doing in countries in West Africa as we test this and build out the support documents, the support workshops, etc., to help implement this framework. The prep work is building the right team, getting the right people around the table, doing an analysis of the information ecosystem. Where are the conversations? What's being said? In which channels are they? What is our ability to access those channels, both online and, I can't emphasize enough, offline as well? Build that social, or configure that social listening system. Start doing the listening. Pick up the misinformation, but also the questions and concerns. And this is the other thing that I will keep coming back to is, in the longer term, we need to be able to see through that fog of misinformation to hear the perfectly reasonable questions and concerns that people may have around, for example, the SARS-CoV-2 vaccines. And we can't allow the misinformation to kind of fog our glasses, because the real work is understanding people's concerns, understanding the questions they have and answering them in a way that that satisfies people, that reassures people, that builds people's trust in vaccination. But there are also misinformation narratives circulating, so building a rumor log to categorize them, a log that should also be categorizing the questions and concerns, not just the misinformation narratives. Then going through an assessment process where you understand the potential impact of those rumors to decide whether or not to act, and then producing through analytics and good thinking, actionable insights that inform the strategic engagement on the ground. So that's the general framework, and that's in the guide. I mentioned the digital interventions and assessment lab. The idea here is to really take what already big retail companies are doing to understand what the best color of their Coke can is for a 13 to 14-year-old female demographic in a certain region in a country. So setting up and developing protocols for rapid A/B testing that can be implemented by anyone. Coming at this from two directions. One, kind of reverse engineering from what we're hearing on the ground, so that we're starting off by a solid understanding of what are the narratives that are circulating, the concerns that people have. Also reverse engineering from the where and the what. So where are the conversations happening, which platforms, what is being shared on those platforms, so that when we start to develop content, messaging, narratives, they're in an appropriate, culturally appropriate, contextually appropriate format. And once we've created that, and building all of this on the science, the behavioral and social science that we have, that may be, and I'm going to come to a minute on how we can vaccinate people against misinformation. That may be general content, it may be pre-bunks, it may be debunks, rapid A/B testing that. We're also going to be doing randomized trial studies this year. But in general, setting this up at a country level so that as content goes out there, we know that it's as contextually relevant as possible for our target audiences. That involves the Yale Institute of Global Health, which is a center of excellence in the behavioral underpinnings of vaccine decision making, and PGP, who have already been working on vaccination and other public health programs, and who have a fantastic creative department, so that the whole package operates in a very rapid cycle, so that we can respond rapidly to countries' needs. Now, I want to just spend a few minutes on prevention and control. So let me say another 5 minutes. I want to give you a few ideas about what's out there that we know works. And this is essentially in 3 buckets. I'm going to focus on the first 2 buckets today. The first bucket is pivots around the idea that we can vaccinate people against vaccine misinformation. I'll tell you what I mean by this in a minute. The second piece is that misinformation is a problem, but what we do know, for example, a recent report from one of our partners, First Draft, clearly identified that information deficits are as or more important than misinformation narratives that are circulating. If there are holes in the information, in the good information that people can access when they have questions, then the misinformation fills those holes in. So we need to set the agenda. We need to stop being reactive. We need to start being proactive. We need to set the agenda. We need to shape the conversations around vaccination. I don't want to talk about what I used to call, I call infection control. We've seen social media, some of the big platforms making systemic changes to limit the spread of disinformation. I don't want to get into that today, but that is obviously a key step that needs to happen as well. We have a decision tree for deciding when to engage. The point here is that by engaging on a misinformation narrative, we risk giving it oxygen. We risk, as I mentioned earlier, making it more familiar in people's minds, and therefore giving it more traction, albeit inadvertently. So we need to decide when to engage, when to perhaps monitor, just monitor. We need to identify the information gaps. And then if we think that it's likely that it's going to get traction, we can actually inoculate, we can pre-bunk or debunk misinformation out there. In terms of pre-bunking, this is like providing people with a general immunity against misinformation, against all kinds of misinformation. It works, the fundamental principle is, it loops back to my universal human value that I don't think has ever been shown by psychologists, but it is that people don't like to be fooled, right? Nobody likes to be shown that they've been fooled. We can help people to see how they're being fooled by misinformation, to understand the deceitful tactics that are being employed by those authors of disinformation to trick us, And in doing so, we provide people with a level of immunity. They are better able to identify misinformation. They are more likely to identify it, and they are less likely to share it. I've given 3 good examples here. The Go Viral game, which is focused on COVID-19, is a great example. Each of these examples, so the Go Viral game, and Informed Health Choices, which is a curriculum, a primary curriculum, have both been shown to have an impact on people's ability to identify and resist misinformation. The curriculum was tested in a really nice randomized cluster randomized trial in Uganda in hundreds of schools. So these are proven tactics. These are proven approaches. That's what we might call pre-bunking. And there's a fantastic handbook out there that I think I've got the link to at the end, that builds upon what you'll find in the Misinformation Management Guide. This is pre-bunking. This is general immunity. We can also provide a specific immunity against a specific misinformation narrative, but it seems like it's best if we follow a certain formula. This is the formula that is the updated debunking handbook. So there you see the link at the bottom, has put forward, that is increasingly being confirmed by studies. The idea here is that you don't mention the misinformation up front. So you don't bust the myth up front, right? You lead with the fact and you get it right. You make it nice and clear and resonant and sticky. Then you give people a heads up. There's misinformation on its way, right? You're about to be fooled. There are tactics, misleading, deceitful tactics coming. Then you show people the tactics that are being used to deceive them. And in that alert, you've given a very weak, a kind of a weakened form of the misinformation where possible. You show them the tactics that have been used, and then you reinforce the fact, so that if you've successfully removed the misinformation from their head, you fill that gap with the fact. There are many things we can do to set the agenda. We need content. We need content that's designed and tested, as I've already touched upon. That content needs to be housed. It needs to be consolidated. It needs to be available. It needs to be, most importantly, shared through trusted voices. So we can amplify the trusted voices that are out there, but we can also galvanize new trusted voices. The International Pediatrics Association has just launched their vaccine trust program. In that program, we've got a module that trains health professionals on how to get into social media, how to become a trusted voice in the social media space. Shots Around the World is a fantastic initiative. Pediatricians initially, but more broadly health workers who come to the aid of another health worker who's being attacked on social media. We can mobilize youth. We need to think of other community leaders, religious leaders, etc. We need to get them into the social media conversation. I don't want to get into social media platforms today. There are different things that they can do. There's a lot of, there's some good reviews of this out there now. But we do know that these systemic changes can have an impact on the spread of misinformation through these platforms. So in summary, Cam, I'm going to stop here. In summary, if I leave you with 3 key points, they are, we need to take a strategic approach to this. That strategy needs to understand the situation. It needs to mobilize all of the right partners and align them and get them going in the same direction. It needs to be driving multifaceted, coordinated actions. This brilliant discovery that we can inoculate people against misinformation. How do we inoculate people against what's circulating now, but also how do we build innate immunity against misinformation? So the country of Finland has had something to this something around this idea within their national education curriculum for many years, and it's known as it's consistently rated as the country that is the most resistant to misinformation. But most importantly, when we're looking at misinformation in relation to vaccination, in relation to public health more broadly, how do we hear through the fog of disinformation to ensure that the people who have questions, and perfectly reasonable questions, feel heard, that we are able to understand what their questions are, and that we're able to answer those questions in a way that doesn't just make them feel heard, but perhaps even through those trusted messengers feel felt. So I'll stop there, Cam, and hand over to you. And the guide is available. Please feel free to share it anywhere and everywhere. Download it, share it with your networks. We hope that it's a good starting point for anyone who's thinking about what they can do to start to tackle this challenge to our immunization programs.
So thank you very much, Angus, for that. A round of applause, a digital round of applause for you. I thought it was a very, very robust presentation. In fact, I almost felt that the second half of it needs its own session. It's very interesting to see the operational frameworks that you're developing, the decision trees and the kind of the nuances within that, and some of the partnerships actually that are starting to form. I think it's very, very exciting. And I think that does actually need to be expanded upon. So hopefully we can have another session later on, not today, but I think that deserves it.
Not today, I'm running out of voice.
I just, yeah, I was going to say, there are a lot of questions popping up on the chat from the attendees. Before we go to those, I just wanted to give a shout out because we've had, as you were presenting, Dr. Janet Garin from the House of Congress Representatives at the Philippines join us. Dr. Isabelle Delarue from France, from Epilinks. We have Dr. Helena Oliata from the Ministry of Health Indonesia, from Jakarta. Dr. Ilya Adams from Nigeria. We've got representation from Colombia. The Philippines is very nicely represented. Dr. Kenneth Hartigan Go. We have a wide range with Dr. Raj Shankar Ghosh from the Gates Foundation, all the way from India, no doubt celebrating the cricket result from earlier in the day. But
that was unnecessary.
Brazil.
I've already copped that a few times today, as you might have heard from my accent.
I thought I'd get that in there. Dr. Mariana Hassler from Brazil as well. We've got a wide geographic spread. The Gabon, I can see logging on there as well. Iran, Dr. Harandi. So it's a very, very, hot topic, a very topical presentation. So a lot of questions coming through. I had one, and I know that we're supposed to finish at 4 o'clock, but we might go a few minutes over depending on how these go. But I just wanted to ask one question. When you look at France, just as an example, I'm not singling out any countries, but just as a slight comparison in terms of vaccination uptake, we here on about 4 million as of today, and that'll be updated at 5 o'clock by the UK government. But at the moment, it's about over 4 million people have taken the first shot in terms of the vaccination program that's being rolled out. In France, that's significantly lower. I think a few days ago, I haven't got their update at the moment from the COVID trackers, not updating, but from before the weekend, it's around 190,000. And I know they were late, perhaps slightly later in terms of the timelines of starting. But and some of the points you made there really pointed towards moving from a centralized communication strategy to a more localized strategy. So I wanted to put you on the spot and ask you, their move to bring a management consultancy to look at that. What are your views on that, and how local do you think they need to take it in France in terms of the messaging coming out of government for vaccination uptake?
So first of all, thanks for the question. First of all, le guide est en français aussi. Je vois qu'il y a plusieurs français. So the guide's in French. It's coming in Spanish. You mentioned attendees from Colombia. It will be in Italian soon as well. We are keen to get it in as many languages as possible. I think the first part of the answer to your question is we mustn't confuse acceptance with uptake. And vaccines many times we have low vaccination rates because the vaccines are not reaching people, not because people are saying no. And vaccine hesitancy in some ways is an easy solution, an easy explanation for, in fact, failure of systems to ensure that vaccines are easily accessible to the populations who should be getting vaccinated. I think that the delay in France is an important reason. Just the delay of the start of the program is the primary explanation for why we see different numbers. Once that program starts to gear up, I think we'll see that the numbers start to approach each other. Your point around how granular should our communications become, I think the answer is, how granular can we make them? Okay. The idea of a more sophisticated social listening strategy is to better understand the concerns and questions that people have, and the context within which those people are having those concerns and questions, so that we can frame the responses, whether it's the information that we put out there proactively to answer people's questions when they come across it, or whether it's specific responses to questions that arise, or whether it's these pre-bunks or debunks of misleading disinformation narratives. The better we understand the context in which these are getting traction, the better we can customize or tailor the responses in a way that, as I said at the beginning, the information is as sticky as the misinformation. So, the strategy that we propose is a joined up strategy, so that it's a virtuous cycle of ongoing listening, detection in real time of questions, concerns, rumors, and responding to those as best as possible with, the lab is our first stab at this, with content, with responses that are framed for the people asking those questions, that are framed in a way that they will resonate with people. And that means that there's no packaging public health messaging and throwing it over the fence at everybody. Has never worked, and it never will work. It is important that we get consistent, clear, regular communications from a government. We know that, and that those communications communicate the uncertainty of anything that is being said. But beyond that, as far as possible, we need to be able to frame things for people. We need to talk to people where they are, Cam, not about what matters to them, not talk to them about what matters to us.
And I suppose that's a great answer. And I suppose some of that really is going to be about developing local champions in terms of, perhaps you've mentioned on some of your slides, even religious leaders, some of those people, people that are trusted, if we want to use that word, or have resonance with those particular communities that we're trying to reach. On your point of the political side of things, Dr. Garen's made a point here. Vaccine literacy amongst country leaders is a must. COVID vaccination will never be successful if hesitancy is not addressed. So really, approaching the political class as well as the communities on the ground, and developing that literacy around vaccines, educating them around this is a must. So that's from Dr. Jeanette Garen from the Philippines. I'm going to move to some questions, if that's okay with everybody. And I'm just running through the chat here to get those. So just literally a second.
Cam, while you look at those questions, can I just respond to one thing you said? So, at UNICEF and partners at the country level are doing this kind of engagement all day, every day. They have people out in communities. This is not reinventing the wheel. What it is saying that kind of approach needs to be taken up to the digital level as well, because people are living and communicating in digital communities as well. So, it's very important. That piece of this is not some brilliant insight that I've had. Yeah. This is, organizations like UNICEF know how to do this. And our aim here is just to help them do this even better. But it also means finding those, as you touched upon, those trusted messengers in these online communities. So a really nice example of this is PGP actually had an intervention in the US. So this is in the US, but we would love to take this to other countries, where they activated what they call micro-influencers. So these are not your football stars, right? These are people who might have a community of a few hundred or a few thousand people that they talk to about any subject. And they would provide these influencers with either with content to share or even just cues. You know, talk to your community about, and in this case it was influenza vaccination. And this is a very powerful approach and was shown to have a significant impact on people's intentions and acceptance of vaccination. So, you know, there's a lot of stuff out there already that's working. The question is, how do you adapt it to these new contexts? And you know, from Dr. Garin there, vaccine literacy is important, yes, amongst country leaders. What's most important is that country leaders follow the science and not the politics when it comes to public health. So, you know, politicization of public health inevitably ends up costing lives and livelihoods. Even if country leaders don't understand how vaccines work, they have to understand that science works, and you know, things need to move forward at the speed of science, guided by the science, not guided by the politics.
That's a fair answer. I've got a few questions coming through, Angus, if that's okay. So Dr. Milan Carrera is asking from Rome in Italy, how do we make those people who spread misinformation accountable? Is it possible? I suppose that question's been asked because some of the points you touched upon are some of these that have a strategy to them. The diagram you showed of the targeted misinformation flows, you know, they've got a strategy behind them. They've potentially got funding behind them. So there's some kind of argument to be made, I guess, and this is where probably Dr. Carrera's asked that. How do we make these people who spread misinformation accountable? Is it possible?
Yep.
And what's your opinion on that?
People who create disinformation, who manufacture, engineer it, and spread it, use deceitful tactics, and they have malicious intentions. Okay, that's the definition of disinformation. It comes from a Russian word coined by the KGB. As I showed in the inoculation methodology, if you can help people identify those tactics, or probably, but we don't have as much data, those malicious intentions, then you can inoculate them. Now, I've identified, and you might remember this, Cam, in 2016 was the first time I talked about this, 3 intentions: monetize, politicize, or polarize. For vaccination misinformation, it almost always is a question of monetizing that disinformation, using that disinformation to polarize societies or to politicize, for political gains. Now, if we can identify and highlight those intentions, we can undermine their capacity to influence people. We can also influence, you know, the social platforms to remove those people. And we have a couple of examples in the last couple of months of deplatforming of accounts that were making a lot of money out of vaccine disinformation. So that is possible, but obviously that's not going to happen very often. At the other end of the spectrum, at an individual level, we can all take responsibility to not spread it in the first instance. And there's a brilliant tweak, there's a brilliant nudge on Twitter now. If you share an article without having clicked on the link, it asks you if you want to read it first. Now, the reason that's come up is that a study showed that up to 60% of shares, the person had never even looked at what they're sharing. So we can train people in that pre-bunking approach, those inoculation approaches with games, with education curricula, etc., to identify misinformation and to stop and think before they share it. And we can also challenge our peers and our family and our entourage when they start spreading or recounting disinformation as well. So it can happen at different levels. There's many people will never be able to hold them accountable, but at the same time, we need to be building those trusted voices so that people are more likely to just listen to the people that they trust, that who are giving them the reliable scientific information, than worrying so much about the people who are spreading the misinformation.
Yeah, and I suppose part of that accountability is a great answer. Actually, part of the accountability there is there's got to be some form of evidence of misinformation, and I suppose that leans into how much responsibility do social media companies have themselves. You mentioned the Twitter nudges. We've also seen quite a kind of obtuse example of that in terms of getting rid of the President Trump's Twitter account. There are certain I'm not saying that's the way to do it, but there is a sense of responsibility growing within the social media platforms. And I wonder how that's going to extrapolate moving forward to the Facebooks of the world and these new kind of apps and the real the digital cohesion between people. I wonder how that's going to resonate and translate into that as we move forward. We've got other questions. Dr. David Robinson from the UK, how could trusted persons explain the importance of vaccines more effectively? For example, school teachers, senior doctors, scientists, and government advisors. And I think that does lean, that kind of, I suppose, knocks on the door of the vacuum in terms of information into which the conspiracists start, entering and forming their kind of chambers and voices. So how could trusted persons explain the importance of vaccines more effectively?
With Professor John Parrish Sproul, who's at Indiana University, IUPUI, we developed a training course for health professionals on how to talk about vaccination. And the crux of this course is not the what, it's the how. Because what we understand is that when people have questions, when they're already a little what we call reactive, and when they're putting forward these things that they've heard that may already be beginning to stick to whether they want it to stick or not, the how you speak with people is more important than what you say to them. And I touched upon this earlier on in the presentation. We need to make people feel heard before we answer their questions, because until we've got somebody in a receptive state of mind, whatever we say will just bounce off. I'm being very general here, but there is a lot of neuroscience, psychological, and social science behind what I'm saying.
Yeah.
So we can train people to talk differently with their patients, but also with their friends and their family. And the first thing, if anyone wants one takeaway, is listen to the person first and repeat back what you've heard to make them feel like you've heard their concern.
Yeah.
Then, of course, as we've touched upon, Cam, you need to start trying to frame the information that they need within their worldview, within the way they see the world. So that might mean explaining in different levels of scientific language. It might mean coming up with metaphors or comparisons that resonate with people. But the most important thing is to start doing it. We just don't have enough voices in the conversation. And what I love about that question is that you mentioned school teachers. You mentioned others who could be in this conversation, biological scientists. There can't be a biological scientist in the world who doesn't believe in vaccination. Where are they in the conversation, et cetera, et cetera? We need more voices. We need more positive voices, because misinformation, as you said, fills the vacuum.
Yeah, perhaps a lack of confidence that they don't know how to engage with the misinformation crowd, and perhaps this type of report, your approach will breed confidence into that. So I think that's and certainly I think it's obvious that it's going to be through, you've mentioned this yourself, through partnerships. And so I was going to put this question out to everybody and yourself, Angus. If any of our audience wants to contact you in terms of potential partnerships, we've got quite a wide array in terms of the job titles, ministries of health, different countries, as you can see. Are you open to that? Are you open for them to contact you directly on that?
Of course, very open. Please, anyone, don't hesitate. I see Stephen says who's providing the funds. So this is a UNICEF well, it's funds that UNICEF received from Gavi at the moment, and from one other funder. The other partners are providing a substantial amount of in-kind contribution, whether it's Yale University, PGP, or First Draft. We are currently piloting all of this in West Africa, understanding how you make this, how you get these strategies in place, and looking to move very rapidly to other countries around the world. And we are seeking additional funding because we want to take this to scale. I mean, we see this mechanism as being a fundamental gap in any immunization program. And what we would like to do is surf, in a sense, the COVID-19 misinformation wave to build capacity and capability in countries so that this becomes routine. Because, Cam, this is not going away, right? We've been dealing with this since we started scraping, cowpox blisters, and we're going to be dealing with this in 10 years and in 20 years and in 30 years. We've only eradicated one disease. We're going to be vaccinating people in 30 years' time, and we're going to have to be doing this, and we're going to have to be doing this better.
Yeah, absolutely fair point. I suppose on that, Dr. Nebe from Nigeria has put a thing saying that the development and distribution of COVID-19 vaccine has been received with mixed reactions, and I'm assuming that's obviously from a Nigerian perspective. How will the negative effects affect massive global population campaigns? I'm assuming that's been answered somewhat in terms of the localized flavor of things that you're trying to reach, but any thoughts on that? How will the negative effects affect any massive?
Yeah, I mean, we've been, as I mentioned in the kind of themes that we look at. So we are extremely concerned, and we have substantial evidence that the pandemic is having serious knock-on effects on routine immunization, for example. So not just access to routine immunization services, whether it's a decreased access or people's decreased in people accessing because of their concerns about the circulating virus. But it's also likely to be having an impact on routine immunization programs through the impact on public trust in general. So, if the government is managing this pandemic in a way that is not nurturing public trust, is eroding public trust because, for example, they're not being transparent, they're not communicating regularly, they're making odd decisions, that loss of trust, we know, will have knock-on effects on routine immunization. We're also managing the introduction of a new oral polio vaccine. Everything is interconnected now. And so the answer to that is that we can't look at what's being said about COVID-19 and the SARS-CoV-2 vaccines without looking at what's being said about routine immunization, what's being said about other vaccines. We need to be understanding the interaction between all of these.
That's very interesting you say that, and no doubt it's the correct thing to do. We ourselves, even in our humble kind of little world, we're also trying to develop a continuum between different webinars because it is so interrelated. So we want to see that this year. It's one of our missions for this year. On that, I suppose, there's a couple of questions that have just come up. I just lost them on the screen. Sorry there. So in terms of trust, Dr. Helena Eliata from the Ministry of Health Indonesia, what's the best strategy for the community to doubt because of belief and what's the best strategy for the community because of belief and enhance hoax information, misinformation? It would seem that health education and key persons, healthcare professionals, as role models do not seem to work. I suppose that's from an Indonesian perspective. So trust. Who do you trust? I suppose that's that question there.
Yeah, that's the first question I would ask. Who do the people trust if they're not trusting the providers, the health providers in this instance? And once you've identified who those people are, those trustworthy people, how can you activate them to speak with people and to answer their questions and their concerns? Yeah. The trusted messenger is as important as the message itself.
Yeah, absolutely. And I suppose part of that, and this is a question from Dr. Semu Adeni from Sokoto Children's Hospital in Nigeria, who's working actually in Noma the polymicrobial disease there that we're covering with MSF on the 11th of February. And he's asking, and this is quite an interesting question actually, here, and he spoke about Sokoto and that area of the Sahel, here the community believe that COVID-19 is a disease of the West and affluent people. How can we debunk this belief? And I think that's very interesting in terms of what you just said about drawing in from the different experiences, because Ebola went through this as well in terms of total mistrust of the West. Until they integrated their isolation and treatment by bringing in local voices and integrating that, they couldn't really get over that kind of persistent. So Dr. Edeni is asking, here the community believe that COVID-19 is a disease of the West and affluent people. How can we debunk this belief?
Mm-hmm. I think as you touched upon, it's important to understand that this belief has strong roots, and we've seen this. I've seen this in other conversations within the African continent. That's not surprising, and so we need to understand that it's getting traction because of that pre-existing mistrust. What we're talking about here is how do we make the disease salient to people? How do we make it relevant and real to them? And what we know in vaccination is that just yelling at people that a disease kills people is not necessarily the most effective way to get them to understand that this disease is salient and is relevant to them. So we need to make people feel vulnerable to the disease, not just understand that it's a dangerous disease, but personally feel vulnerable. And we need to make them feel like there's a chance that they could catch it. Yeah. And then hopefully we also give them in the same breath a solution. We explain how the vaccine is a solution. But the important thing is to start to try to understand how you might be able to make this relevant to people, understanding that they're already mistrusting, but are there personal stories that can be shared? Will people listen to the accounts of the health professionals who are managing the cases in the hospital? Will they listen to a trusted voice who knows somebody who's been sick and explains that? You have to make it personally relevant to people, and there's no single solution to that. Yeah. So that's a very good answer. So I think we are coming up to 4:15, and I know we had said 4 o'clock. So I just wanted to ask a question. It's 13 minutes past 4. Are you okay with one more question? Are we? And is everybody there? Sure. Some people have dropped off. Thank you, Angus. I appreciate that. So Professor Kenneth Hartigan Go from the Philippines making a statement, actually. I suppose this is just in line with what you just said. When we interviewed medical students in the Philippines about their concerns, a majority of these students realized misinformation and disinformation activities are quite prevalent. They are seeking for workable solutions. So perhaps a potential partnership road there to the Philippines through their work. That's something as a statement there. So not really a question there, but well, I think we can share this presentation afterwards, but I've given a few leads on games and curricula that can be used to enhance people's ability to identify misinformation and to start to inoculate them. And we'll certainly be working on one this year, a really great game called Cranky Uncle that has been tested and shown to increase people's resistance to climate change related misinformation. We want to create a vaccination module, but please go to the guide. Please go to some of the references in the guide. We now have concrete examples of what works, and what we need now is to people to pick up those examples and adapt them to their context and implement. Brilliant. There's an extrapolation. This will be the last one, I think, from Dr. Janet Garin of the Philippines, ex-Senator Garin, part of the House of Representatives there. Will it be possible for an international body to list down countries possibly infected with infodemic? That's a very interesting question.
I suppose there's a hidden question in there. Is there a need for an international body to, I suppose, police that in some way? Do you think that's a natural extrapolation of your work, the digital work, in the solutions half of your presentation? Do you think it will lead? You're giving tools by which people could police it. Do you think there will be an international body eventually on that?
That's a difficult one to answer. We're hoping that this collaboration, which we're calling the Vaccination Demand Observatory, will start to provide some kind of a global perspective on what's happening. But there are already some examples of that. And really, what's important is that things happen at the country level, so that everything, the listening, the understanding, the evaluation, and the development of strategies happens at a country level, because I don't really see that a global perspective brings much value to contextual challenges. In terms of more broadly addressing it, I mean, the WHO is taking a leading role. They coined the phrase they reinvigorated the phrase infodemic, infodemiology. They've been training infodemic managers with partners, and we were part of that as well. UNICEF is finding its role as well, but really, my organization is used to working on the ground, and that's where we think we can have the most impact. In the end, I think that's where the most impact will be, and that's where we need to concentrate. I don't see a simple global solution to this, but I do see the need for the global partners to be joining up and working together, and we're certainly, through the Vaccination Demand Hub, seeing how we can coordinate this with partners like the WHO, Gavi, etc., to make sure that we are working in a coordinated manner.
Yeah, de-risking this through partnership certainly is the way forward. Dr. Rosabelle Drury from MSD is asking, what does Angus consider the role of industry, the vaccine manufacturers, to be given the regulations? How can we help this infodemic from his point of view? So there's, potential partnerships there, but within this kind of from the manufacturer's perspective, I suppose. Yeah.
I mean, everybody needs to play a role. All the voices need to be out there, and many years ago, I heard an account where a company in the US was asked by their public health, the government public health department, why they were so quiet around an issue that had risen around one of their vaccines, since it was their vaccine. If manufacturers are confident and proud of these miraculous products that they develop and are not out there being part of the conversation, then that actually sends the wrong signal. But in the same breath, we need civil society organizations, we need teachers, we need medical researchers. We need everybody. We need all of the voices at this in this conversation in order to provide those tailored resonant responses to people's questions.
A lot of people are saying thank you, Angus. A lot of people, Dr. Lee Haynes from the LST.
And some people are thanking you for the excellent moderation as well.
Not very good moderation.
I echo them.
And I think it's absolutely fantastic, your work. Gary Finnegan is on the chat as well, so a big shout out to the other co-author, Gary.
Yeah, my co-author.
So that's fantastic that you're able to join us, Gary. That's fantastic. There's so many questions I've left unasked in terms of this that I'm afraid I'm going to have to ask you to commit to another session further on, and we can, obviously chat offline and organize that. I think there's a massive appetite and a total need for what you've got, and especially the second half of that presentation. I really want to pull that open a bit. Would that be okay, Angus? They're asking for you. It's kind of asking.
I'd love to, for example, come back and show people what we're doing, what we've, how we've progressed, the kinds of processes we've put in place in countries, what we're hearing, the content that we're developing. I'd be happy to share that in a couple of months' time, especially as we hope to scale to a number of other countries very, very soon. And as you said, happy to hear from people as well.
Brilliant. So what we're going to do is obviously edit this and get the recording out and across social media and across our own networks as well, so everybody's got that. I just wanted to say an absolute legend, Angus Thomson. Thank you very, very much for making time for this webinar. Thank you very, very much to all of the audience from Colombia all the way to India, Africa. We've got it covered in terms of the geographic spread. Absolutely love the fact that we're able to get so many different viewpoints and people on. I absolutely love that. And so looking forward to a 21 full of debate, discussion, and building this continuum of discussion, ideas around various topics. So it's not just, webinar here, webinar there. Honestly, Angus, thank you so much for your time there. I think it's amazing. Thank you. If that's all right with everybody, we're going to sign off, I think, now. I hate saying goodbye, actually, but I'm going to say
thanks for your excellent moderation.
Absolutely not.
It's okay. We'll meet again soon, Cam.
We'll meet again. We'll meet again, Angus. Right, you take care. All right. And hope the barbers will be open soon because it's lockdown in East Finchley.
Yeah, that's not a problem that I have.
Keep safe. Yeah, well, I think it's something similar. Keep safe, everybody. Yeah. Right, everybody have a great, until we next week. I think our next webinar is next week. You can see our schedule. We've got some great things planned. Take care. Bye-bye. I hate saying goodbye.
Bye.
Goodbye.